Hello, everyone. My name is Leonel August Rodriguez. I'm the VP of Business Development for Access Medical Labs. Welcome to another episode of Access Live, where we bring you insight from leading medical experts. We do ask that all questions are asked in the Q&A, as they will be answered at the end of the session. Today, we have an individual who is no stranger to Access Live. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker. She has been featured on CNN and PBS and is the author of 11 best-selling books. Today, she will be speaking on a subject which I personally find a lot of interest in, being that I too want to maximize my male hormones. She's a dear friend and a brilliant woman. Without further ado, Dr. Pam Smith.
Thank you so much. Hello, everybody. I hope you're all having a grand evening or afternoon, depending on where you're joining us from. We are going to talk about male hormones, really from a viewpoint of maximizing them. And we're going to look at it. Many of the references are basically on the slides. For those of you who want more, they're in my brand new book that just came out a month ago called Maximize Your Male Hormones. So it is sold out on Amazon. So if you want a copy, then contact Access Medical, because they will be getting a supply in as soon as the next printing goes through. When we look at andropause, it's an absolute or relative insufficiency of testosterone or its metabolites in relationship to the needs of that individual at that time in their life. So when we talk about hormones, it's kind of honestly, it's hard to describe them without knowing really how much hormone someone actually makes. So as you can see, for a male, they really make about 5 to 8 milligrams of testosterone a day. And for a male, the testosterone actually changes 4 or 5 times throughout the day. Men do make E1, A2, and E3. How much E3 is normal is still a little variable, but there's the E1 and E2. There's the DHEA. So the DHEA-S is the bioavailable, and then the DHEA is the total plus the bioavailable. So that is really the daily hormone function. What is really functions of testosterone? It is a sex hormone. There are receptors all over the body. For example, there's receptors, not just in the gonads, but even in the eyes. It's involved in the making of protein and muscle formation. It helps manufacture bone, improves oxygen uptake throughout the body, helps control blood sugar. It's needed for normal sperm development. It regulates acute HPA responses under dominance challenge. It does help regulate and lower cholesterol, helps maintain a powerful immune system. It aids in mental concentration. In fact, for men, testosterone actually equals memory. It improves mood. It helps protect the brain from Alzheimer's, and it regulates the population of thromboxanthine A2 receptors on the megakaryocytes. So there are some of the references for you. So what are the actual signs and symptoms of andropause, or what sometimes in the medical literature they're calling late onset hypogonadism? Fatigue, tiredness, or loss of energy. So fatigue is a very common one. Depression, low or negative mood, irritability, anger, or bad temper. There is a term for that called grumpy old men. Why do they have that term? They do because of loss of testosterone. Anxiety or nervousness. Memory and concentration are not as sharp. Of course, sexual drive and libido are decreased, as are erections. Decreased intensity of orgasms, weight gain, backaches, joint pains, joint stiffness, loss of fitness. People feel overwhelmed and overstressed. They don't perform as well in their job. A decrease in physical abilities, bone loss, cholesterol goes up, increase in heart disease, blood sugar goes up, and people can even develop metabolic syndrome. So what does the actual medical literature say? What is the science? Low testosterone levels related to increased risk of coronary artery disease? Yes, from the European Heart Journal. These studies show the same thing. Mortality increased due to cardiovascular disease when testosterone is low. Here, studies showed a possible correlation between low testosterone, erectile dysfunction, and conditions associated with higher cardiovascular risk. This study revealed that men with coronary heart disease that were under the age of 45 had total and free testosterone levels significantly lower than controls. Here, serum free testosterone levels were found to be inversely related to carotid intima medial thickness and the plaque score. Here, related to arterial sclerosis, low testosterone related to type 2 diabetes and metabolic syndrome. Lots of references, not just a few. This is a very important slide. Since testosterone has been shown to lower blood sugar levels, the Endocrine Society now recommends measurement of testosterone in all male patients with type 2 diabetes, and they recommend testosterone. It actually is one of the main treatments to regulate the blood sugar. This study showed that low testosterone predicts mortality from cardiovascular disease. This study showed that low testosterone was associated with an increased risk of all-cause mortality, even cancer. Low testosterone, again, all-cause mortality. Testosterone levels began to decrease at about the age of 40. Then all these risk factors go up. More articles on increased risk in CHD. Here, increased incidence of coronary calcium score going up, peripheral artery disorders, calcification goes up when testosterone goes down. How about low testosterone levels in hypertension? Now, people always say, do we really need to replace hormones? Isn't it natural to go through andropause or male menopause and not replace hormones? Aren't we doing something unnatural? No, we're not. We're actually just going back and helping rebalance the body. And here, low testosterone levels, this study showed that the concentrations are predictive of hypertension. Here, congestive heart failure. Men with chronic heart failure, anabolic hormone depletion is common. They also have a poorer prognosis. This is from Circulation. I deliberately today chose articles from very conservative medical journals. An animal trial, development of cognitive decline if people do not have testosterone. Here, it plays a very major role in brain functioning. In fact, testosterone, as we mentioned, decreases beta amyloid plaquing. In this study going back to 1997, free testosterone predicted age-related decline in both visual and verbal memory. Low levels showed the same thing here. This Hong Kong study showed the same thing related to memory. In this study from neurology, males that have a higher ratio of total testosterone to sex hormone binding globulin have a lower rate of development of Alzheimer's disease. Here, patients with Alzheimer's have been shown to actually have a lower ratio of total testosterone to sex hormone binding globulin than controls. And this prospective longitudinal study, the risk of Alzheimer's disease was decreased by 26% for each 10-unit increase in free testosterone at 2, 5, and 10 years before the diagnosis of Alzheimer's disease. And of course, low levels of testosterone may occur prior to the diagnosis of Alzheimer's. Low testosterone has been associated with mild memory loss too. That's not related to Alzheimer's disease. So lots of correlation here with spatial performance. Studies done in animals show the depletion of androgens result in increased pathological conditions, increase in antibody levels, increase in neurologic and neuronal death, and hyperphosphorylation. Here, testosterone and dihydrotestosterone have a positive impact on memory as they change. There's a negative impact Same in these trials as well. In this study, the total testosterone was not indicative of cognitive decline. However, the bioavailable was. In men that have undergone hormonal treatments for prostate cancer with suppression of endogenous testosterone synthesis and blockade of the androgen receptor, the studies have shown there is a beneficial effect on verbal memory, but an adverse aspect on spatial performance. In some patients, plasma amyloid levels elevated as testosterone levels declined. In this study, when treatment for prostate cancer was discontinued, memory actually improved. So I think I've made a good case today on why do we want to give hormones when they decline. Is it sexual function? Of course. But testosterone lowers cholesterol, blood sugar, blood pressure, helps prevent heart disease, helps maintain memory, helps with weight control. It's really all of these things, insulin regulation. So hormone replacement for men is just as important as it is for women. So let's actually look at replacement. We do want to do basic lab work, and you can do all of these by blood. But what I'd like to suggest to you is the best way to do the testing is by salivary. Now, why am I going to say that? It's because there are 6 clinical trials showing that cortisol, the stress hormone, and you have to look at cortisol to look at the other hormones, cortisol is best looked at by salivary testing. So there's no dispute whatsoever. Also, there's 3 clinical trials showing that if the hormones are put on the skin, and we're going to look at putting testosterone on the skin and why, if the hormones are put on the skin, they do not show up in the serum. So honestly, I never do serum testing except for pregnenolone and sex hormone binding globulin and PSA and those kind of things, because I'm going to start using salivary from the very beginning, because I want to compare apples to apples, because for the rest of the time, I'm going to do salivary testing for the remainder of the patient's life. So how often do you do testing? You start the patient on hormones after you've done the first test, repeat the test in 90 days, and then do a salivary test every 6 months thereafter. Very early on in anti-aging medicine, we tested people only once a year, and we discovered because of cortisol and thyroid and other things, that's not enough. And so it is important in men as well to look at E1 and E2. We do look at progesterone, testosterone. They can all be looked at by saliva, DHEA, cortisol. It's fabulous to look at it that way. A digital rectal exam should be done every 6 months as well. When you look at a PSA of less than 4, but rising by 1.5 in 1 year or 0.75 per year over 2 years should have further evaluation. Or if the PSA is above 4, the patient in both of these circumstances should not be given hormones. They should be sent to urology. If they're already on hormones, they should be stopped until the patient sees urology for a prostate biopsy or other evaluation of their prostate. So let's look further at estrogens. Estrogen levels in males, yes, men, as we mentioned, do make all 3. It's important. Right now, we usually measure at least E1 and E2. Males do need a small amount of estrogen. They need it to maintain memory, and they need it to maintain bone structure. Too much estrogen, and it aromatizes, then they end up with an increased risk in prostate cancer and heart disease. So we want estrogen dead center of normal. An early study showed that E2 binding in numerous male tissues and estrogen receptor 1 and 2 each show unique distributions and actions in males. So it's not just women that we look at this in. Exogenous estrogen treatment produce male reproductive pathologies in laboratory animals and in men. So again, too much estrogen is not good, too little is not either. And estrogen's main receptor is essential for male fertility, development of the ductals, epididymis, and prostate, and the loss of only the membrane function of estrogen receptor 1 was sufficient to induce extensive male reproductive abnormalities and infertility. So we need estrogen receptors just even for fertility for men. Expression of all of this is in this article further. So how do you stop the aromatization to occur? How do you stop testosterone going into estrogen? What do you actually do on Monday morning? There's a lot of things you can do. In the early days, everybody gave an anastrozole, and you can still do that, but it can have side effects. My personal favorite is the number 1 on this slide, and that is Chrysin. I love Chrysin. It can be given PO or transdermally. Honestly, I never see anybody give it PO. We give it transdermally. It has no side effects whatsoever. And in my personal practice, I can tell you it's worked in every single patient. So I love Chrysin. That is my go-to. Zinc, flaxseed, EGCG will also work. And then, of course, anastrozole. And this is from a recent article. Ways to increase aromatization. What happens if you're not aromatizing enough? So inflammation, can be a major cause here. Obesity, high insulin, excessive alcohol, mold, and chronic inflammatory response syndrome. So you can get aromatase too high, too low when all of these things happen. Estradiol does have a protective effect on the brain. And here, serum estradiol and testosterone was shown to be lower in men with Alzheimer's compared to age-matched controls. These medications can lower estrogen in men and cause it to be too low. If you can get them off of these medicines, it would be great. I didn't put on here because I'm not sure if I want to classify it as a medicine or not, but changes in different medications become paramount also with estrogen levels going higher. In fact, when you see high estrogen, that commonly occurs in people who smoke marijuana on a chronic basis. Do we replace estrogen in men? Yes, actually, we do replace estriol. It's experimental at this time, but I do this in my practice for MS and autoimmune encephalitis. Estriol is a treatment for males. So I do a salivary test and I give the amount according to the salivary test because the norms for estrogen are right on the test. Estrogen levels in males can elevate due to increased aromatase activity, alteration of liver function, zinc deficiency, and all these other things. And of course, there's environmental estrogens. So if estrogen goes up, gynecomastia can also occur, erectile dysfunction, decreased sex drive, doubled risk of stroke, higher rate of heart attack, as we mentioned, insulin resistance, rheumatoid arthritis, BPH, and yes, prostate cancer. In this study from neurology, high estradiol in males was associated with an increased risk in stroke. Here, high estradiol increase in acute MI, high estrone and low testosterone were associated with promoting the development of an atherogenic lipid milieu in people with CHD. So same thing here, increase in extremity peripheral artery disease if estradiol is high, increase in acute MI, and elevated levels of estradiol in men were associated with increased incidence in this trial of stroke, peripheral vascular disease, carotid artery stenosis. So I think you're getting the hint here. Elevated levels are problematic. Going all the way back here to 1999, we have known this. So ways to lower high estrogen, we mentioned a few earlier. Let's look at a few more. Decreased dose of testosterone. If you're giving the patient too much testosterone, then it's going to aromatize. And that's why we never want to overdose testosterone because it doesn't stay testosterone. It goes into dihydrotestosterone, E1 and E2. We mentioned some of these. Other things are grapeseed extract, wild nettle root, decrease intake of estrogen-containing foods, and eat foods that decrease estrogen. Other ways to lower estrogen levels, are listed here, even high dose vitamin C, vitamin K, and niacin. So there shouldn't be anyone who's male with a high estrogen. But to make it simple, on Monday morning, my go-to is Chrysin. It really honestly does work in every single patient, but I dose physiologically. I don't overdose testosterone. We're going to talk a little bit tonight about the dosing as well. So what are the actual studies on testosterone replacement itself? When it comes to ED, it does affect 1 in 5 men, the frequency increasing with age and the prevalence of comorbidities. And the available literature does support a role for testosterone replacement for erectile dysfunction, decreased sexual interest. Restoring testosterone to normal in men with proven subnormal testosterone improves libido in most subjects and indeed in more than 50% of men in this trial. It does take 14 to 25 weeks to take effect for looking at erectile dysfunction. So set the expectations there so that the male isn't expecting that a week from now, all of a sudden he's going to have better or less problems with erectile dysfunction. Testosterone replacement in this study improved cognitive function. Here it prevented beta amyloid plaquing. Replacement here, reversal of some cognitive dysfunction. You can't take someone with Alzheimer's disease and all of a sudden turn on the lights and they have memory, but you can reverse some cognitive decline with prescribing testosterone. It's been shown to help with mild cognitive impairment as well, help decrease beta amyloid production, and here it improves spatial cognition and verbal fluidity. Older men without dementia, testosterone replacement reduced working memory errors. So even in people who have just a little bit of change in their memory. And in this trial, testosterone improved verbal and spatial memory as well. Here, global cognitive function. So are there a lot of studies showing that testosterone is neuroprotective? Yes, including this one from Psychoneuroendocrinology 2018. More studies on memory. This is a 2016 trial. Here's studies from 1999 on coronary artery disease. Short term, and this is a quotation, administration of testosterone induces a beneficial effect on exercise-induced myocardial ischemia in men with CAD. This effect may be related to a direct coronary relaxing effect. Here, a decreased HDL-C and lipoprotein A. We all know how hard it is to lower lipoprotein A. Testosterone itself will do that. The mechanism of testosterone replacing decreasing lipids may be due to its positive effects on abdominal fat and insulin resistance. As we all know, if men put weight on around the middle, it's more indicative of increasing their risk of having an acute MI. Short-term administration of testosterone here induced a beneficial effect on exercise-induced myocardial ischemia. Here they gave it intracoronary and it caused dilatation. Low-dose supplementation from Circulation 2000, men with chronic stable angina, it reduced their exercise-induced myocardial ischemia. And here testosterone replacement was shown to increase coronary blood flow and improve chronic stable angina in this study. And again, we're looking at very conservative journal. Another study, testosterone reduced exercise-induced myocardial ischemia. Here, calcium antagonistic effect. Here, helped with cardiovascular disease, cholesterol. Testosterone replacement can suppress levels of circulating pro-inflammatory cytokines. In fact, testosterone is anti-inflammatory. Mortality-related cardiovascular disease was significantly reduced in this group. The estimated reduction in mortality for the testosterone group was between 66% and 92%. There were 30 non-fatal strokes and 26 non-fatal myocardial infarctions in the control group, but none but none in the testosterone-treated group. Studies have reported reduced cardiovascular risk with higher endogenous testosterone concentration. Again, it helps with blood sugar, pre-diabetes as well. But there is a caveat. Supraphysiological doses, meaning too high a dose of testosterone, increases the patient's risk of heart disease. Start low and go slow. The TRAVERSE trial began in 2018. Preliminary studies were published in 2020, and it was designed to look at the efficacy of giving testosterone, and it showed that too high a dose actually increased the risk of cardiovascular disease. More to come as this trial goes on. Testosterone replacement was shown to be effective in patients with chronic heart failure. Beneficial effects were confirmed in this 12-week study as well of 70 men. And this randomized controlled trial in people with CHF, it took 90 days, had better 6-minute walking test and quality of life scores. Testosterone replacement in people with CHF was shown in this study to improve exercise capacity, insulin resistance, and muscle performance. Here's a study actually showing that it decreased TNF alpha, so absolutely anti-inflammatory. From Mayo Clinic proceedings, and I quote, "There is no clinical evidence that the risk of either prostate cancer or BPH increases with transdermal testosterone replacement." So I'd like to make the argument today that we use testosterone transdermally instead of any other form. Yes, you can put it transbuccally, you can do it IM, you can do it sub-Q, you can do it in many ways, but transdermal is absolutely the best. Here's one trial showing that, so that you don't get BPH. Men that are older with the highest risk of prostate cancer, by the way, do have the lower levels of testosterone in their body. Several studies have shown in the presence of significant insulin resistance, testosterone actually increases insulin sensitivity and improves blood sugar levels in people with type 2 diabetes. It took 3 months. And in these trials, the same thing. But again, supraphysiological doses will actually drive up insulin. So too much testosterone drives up insulin, increases the risk of heart disease. How about testosterone in bone health? Because it's vision, memory, and mobility when we talk about anti-aging medicine. And from this 2021 study, it suggests that testosterone replacement should be considered as one of the treatment options to improve hypogonadal symptoms and bone mineral density simultaneously in symptomatic hypogonadal men with osteopenia or osteoporosis. So when we look at testosterone replacement, for men, it is safe. There's both controlled and uncontrolled studies that go back for 70 years. Usually we save testosterone itself for people above the ages of 42. There's other therapies that I don't have time to discuss tonight, like HCG, Clomid, exercise, etc., that are great to raise testosterone in younger men. But tonight we're going to focus on the prescribing of testosterone itself. So a cream or a gel is usually best. Several studies have shown that transdermal testosterone is physiologic, efficacious, and has a very good safety profile. IM or sub-Q are possible modes of administration. However, they produce highs and lows. Originally, when we gave it IM, we would give testosterone twice a month. Then when we moved to sub-Q, we gave it to twice a week. But if you're giving it twice a week, then the first day, actually, it's too high. The next day, it's perfect. And then the third day, it's too low. So you do get these highs and lows. It's not as optimal. Also, acne and polycythemia are less common with a transdermal form than they are with IM routes. So you don't tend to get acne or polycythemia as much. So again, more reasons for application transdermally. Where do you put testosterone on? The inner thigh or top of the foot are the best locations because there's less hair there. Men sometimes have thicker skin. Because they have more hair, you may need to put the testosterone in a different kind of base. So I usually put my hormones in Versa base, VERSA base for both men and women, but there's a special base for testosterone. And I haven't used it so far in women. Versa base has been fine, but probably 80% of my male patients are actually on this special base called Atrevus. Atrevvis, Atrevus. And Atrevus was made for testosterone only, and it drives it into the skin better. Transference is a major problem, so do be aware it can occur for up to 12 hours. It can transfer to cats and dogs. To prevent it, areas of application should be covered with clothing as soon as the gel has dried, and the hands should be thoroughly washed with soap and water after application. If skin-to-skin contact is anticipated, the area should be washed thoroughly before contact, and swimming and bathing should be avoided for at least 2 hours after application. So it is great to have it compounded by a compounding pharmacy. And the Atrevus is a gel. It works absolutely fabulous. This is another reason why we suggest the hormones be put on transdermally. And this is a study on erectile dysfunction. If you put the hormones on the skin, testosterone works 81% of the time. If you use it orally, which I never see anybody do, but the study looked at this from the Journal of Urology 2000, orally 51% effective. I am 53% effective. So another reason why, honestly, the best choice is transdermal. Dosing 5 to 50 milligrams. And what you're going to do is do a saliva test and just follow exactly what you're going to see on that saliva test. Remember, if you put hormones on the skin, they do not show up in the blood. The hormones that are steroid hormones are lipophilic. And so they don't end up getting into the bloodstream well. They do go right into the tissues. So 3 clinical trials, one done by David Zava. There was one done in Israel, and I'm about to publish the 3rd trial, which we paid for out of our own money, out of the practice, and 5 different offices, 2 different states. Very fascinating. What did we find? We looked at men, women, all ages, all hormones. Any hormones that were put on the skin did not show up in the blood. So need to do salivary testing. Do we do urine testing? Of course. When we look at metabolites, it's really important for men, just like women, to look at 2, 4, and 16 hydroxyestrogen, to look at the downstream metabolite of all the other hormones is very, very important, but we don't dose off of urine. It's a metabolite. And how I break down things and how you break down them may be entirely different. The chrysin I was talking about to lower estrogen can be mixed in the same syringe or pump as a testosterone, or if the patient does not need testosterone, the chrysin can be used alone. It does have a little bit of a yellow color to it, so warn the patient about that. It does not stain the skin, and the dose of chrysin is also 5 to 50 milligrams. Again, I just follow what it says on the saliva test. The same thing with progesterone. Progesterone is very neuroprotective for men. Progesterone is also my favorite way to lower dihydrotestosterone levels. We don't want DHT to be elevated, increased risk in prostate cancer enlargement, increased risk in heart disease, etc., loss of hair on the head. So progesterone is great to lower dihydrotestosterone. It's also important to replace for neuroprotection. So you can put the progesterone in the same syringe. So they can all be used very well transdermally. You can have compounded sterile testosterone injections. So I did put this here. for people who still would like to use injections. And of course, if the injection does say IM, then don't give it sub-Q. You can get an abscess. And lastly, individuals treated with testosterone should be monitored. So again, we measure in 3 months and every 6 months thereafter. If the hematocrit rises above 54%, the treatment should be stopped. And I really do mean stopped. That is what the medical board suggests, not lowered, but it should be discontinued. The patient may need to donate a unit of blood in order to lower their hematocrit. And the hematocrit should be drawn down to about 45 before you reinstitute giving testosterone. The patient should discontinue testosterone also if their PSA is greater than 1.4 or it doubles within a year or greater than 4. The clinical response to transdermal testosterone does vary. People always ask me, well, how long is all this going to take to work? It takes about 4 to 12 weeks to restore the serum testosterone concentration to physiological range, depending on the initial concentration of the hormone. And the lipid profile begins to improve in about 3 to 4 months. Maximum benefit does take up to 1 year. Total cholesterol, 22 months to bring down triglycerides, lipoprotein, and low-density lipoprotein. A decline in fasting blood sugar and hemoglobin A1C can be observed in about 3 months, with further decrease up to a year later. And the effects of testosterone on bone mineral density do take longer. It takes 6 months for initial effect, up to 3 years or even longer. And patients with metabolic syndrome experience maximum benefit in waist circumference, fasting blood sugar, and blood pressure in about 1 year. Improvement, of course, this is always the big question, so I saved it for last. Improvement in sexual desire and function, as well as mood and energy, occurs earlier in the course of treatment, thank goodness, in approximately 3 to 6 weeks. These are counterindications to testosterone use. The patient has prostate cancer, you cannot use it. If it's active prostate cancer, from Morgenthaler's work at Harvard, if the patient is over 65 to 70 and they have a non-aggressive prostate cancer, if there's been no reoccurrence for 3 years, you can consider low dose testosterone replacement. But if the patient's younger, they probably should never get testosterone because younger men tend to get a more aggressive prostate cancer. And I do have older men in my practice that did get an aggressive form. And the urologist will let you know, an oncologist, if it's an aggressive form or not. 3% of breast cancer is in males. So if they have breast cancer, that's a counterindication to testosterone use, or prolactinoma, prostate nodule or indurations, uncontrolled or poorly controlled heart failure, hematocrit, you saw those in PSA, severe BPH, untreated sleep apnea. You do have to treat the sleep apnea first before you would give testosterone. Severe liver disease and severe kidney disease, then you may not be able to give testosterone. Having erythrocytosis is associated with an increased risk of developing heart disease and thrombosis. It's usually secondary to overdosage of testosterone. The answer is not go donate a unit of blood every month. And I see some people do that. The answer is to lower the dose of the hormone. This major study on the risk and benefits of testosterone replacement suggests that a baseline hematocrit should be checked at 3 to 6 months and then every 6 to 12 months thereafter. If the hematocrit is more than 54, then testosterone should be stopped. And this is the actual reference that the medical board uses. So please don't just lower the dose. In conclusion, and then we're going to take questions, maintaining optimal hormonal levels in men is an essential therapeutic tool to aid the patient in achieving optimal health, as you saw, when it comes to sexual function, energy, when it comes to memory, prevention of heart disease, regulating blood sugar. Honestly, it is the ultimate therapy when it comes to anti-aging medicine. Thank you very much.
Dr. Smith, what an amazing session. You truly left our audience in awe as we don't have any questions. However, before we wrap up, I know that you have your Dr. Smith's hormone workshop coming up. If you could please tell our viewers what to do so that they do not miss this.
Absolutely. This is something you really want to do. It is what you do on Monday morning when it comes to hormones. It's going to be held live in the spring. A4M is going to make the announcement on Monday, and it's also going to be available to take online. But we hope you come and join us live because it's a lot of fun to do it that way. It's going to have ongoing sessions every month as well. The first day is, hi, these are all the hormones from thyroid to male, female, to everybody of every age group. The second day is 4 professors presenting case histories, and there's almost 100 years of clinical experience between the 4 professors. And on day 3 is a PharmD to really look at hormone dosing. And myself, I'm actually going to be presenting what we call dosing protocols. I literally have looked at 80,000 saliva tests in my career, and we're going to actually give you, hi, this is what the result is, this is a dose you should give, and you'll be close to 90% correct on the first try, as long as the phase 1, phase 2, and phase 3 detoxification are fairly normal. So if you want information on that, there's 3 ways you can find it. Number 1, you can email me at faafm63@yahoo.com. So faafm63@yahoo.com. You can contact your A4M representative, and you can also contact Access Medical Lab. And make sure that when you contact A4M, or if you contact myself or Access, that you mention that you did hear the seminar tonight, because for people who did, they will receive a discount on this workshop. So we'd love to have you all there.
Wonderful. So in short, you don't want to miss this. Right.
Thank you.
Excellent. No, it's a pleasure. And thank you again, Dr. Smith.
I think there's 2 questions, Leo, in the question box.
Oh, there, you know what? You are correct. So we do have a question here.
Yeah.
So the value of urine hormone testing, it's a bit of a vague question. So I'm hoping that's enough for you to provide us with an answer for.
Absolutely. I think I went over it a little bit, but to be more specific, do you need to do urine testing? Yes, because you need to look at the metabolites or breakdown products. You just don't dose off of urine. Okay. So that's the value. Is it valuable? Absolutely. Should it be done? It's a must, because you want more 2-hydroxyestrogen. Too much 16 increases the risk of prostate cancer, but you need a little bit of 16 for bone structure. You don't want any 4-hydroxy because there's an increase in prostate cancer. In males, you can look at the metabolization of the rest of the hormones, but because it's a metabolite or a breakdown product and not the actual measure of the hormone, we don't dose off of urine.
Excellent. And the second question was, can we use tribulus terrestris? I believe I'm not pronouncing these correctly. Maca, Panax, ginseng to support testosterone.
Yes, if I had had more time tonight, Nina, I would have gone over some quote unquote natural therapies. As I alluded to, actually exercise is the best. But as you have mentioned here, there are great herbal therapies as well. However, those are for people with borderline testosterone. You can boost it up, but if you're talking about most 70-year-old males, is that going to be enough? No. But if you're talking about a 45-year-old male who's willing to exercise and take some of the things you mentioned here, might it be enough? Yes, it may very well.
Excellent. Last question. Any thoughts, or second to last question, my apologies. Any thoughts about sub-Q injections?
Sub-Q injections, again, give you highs and lows. So it's certainly not wrong. You can absolutely do sub-Q injections, but again, the first day, it'll probably be a little too much. The next day, it'll be great. The third day, it'll probably be a little bit too little. So it's not quite as physiologic. And someone in the Q&A box wanted me to mention, here's my book. It's called Maximize Your Male Hormones. Actually, it's the first book written on male hormones in 20 years. And the references we put online, and that way we can update them. So they're not here. You actually get a code to go online and get the references so that they get constantly updated. So there's a zillion of them, or the book would have been twice as thick.
Excellent. Excellent. All right, Dr. Smith, a pleasure as always. Thank you again. And we'll see everyone soon.
Thank you so much for the opportunity. Everybody have a great day and a good evening.
A pleasure.
Thank you, Leo.
My pleasure.